My name is Patrick Kim. I'm with University of South Florida and Tampa General Hospital. ULBD, or the laminectomy, is vast majority of my elective practice, and uniportal approach is my preferred method for doing this procedure. I teach for ITREX, and as our procedures has gotten less invasive, I think the technicality has gotten more complex, and that's because we're trying to accomplish the same amount of decompression while going through a smaller incision. Thank you so much. Yeah, great. And so we talk about the learning curve in endoscopic spine surgery, and especially for ULBD, I think that the barrier, the learning curve, has steered many surgeons away from picking up these techniques. However, I'd like to argue that our scopes and tools has gotten better. With each successive generations of the scope, our working channel has gotten bigger and bigger. For example, here. So with now the newest generation of the scopes, the stenosis or degen scope, now the working channel is about 7 millimeters in size. What that means is that this allows for 5 to 6 millimeters of drill bit and also 5 to 6 millimeters of kerrison. If you think about it, we rarely use these large instruments in open cases, right? Unless you're doing laterals. So that's especially important, especially when you're performing a laminotomy or bone removal portion of the procedure, which was seen as the bottleneck or the rate-limiting step in laminotomy or any endoscopic spinal procedures. So I refer to this mechanical engineering formula quite a bit. We call this a material removal rate in drilling. There are three variables, that is drill bit size, feed rate, and spindle speed, which is the RPM. As you see here, the drill bit diameter plays the biggest role in bone removal rate because it's quadratic to that bone removal rate. Next is a feed rate. I'll get into this in a bit too, but if you can imagine a table saw and if you're feeding the plywood, the quicker you deliver the plywood against the drill, the quicker the bone drilling gets done. Same thing with the RPM. The faster the drill spins, the faster the drilling gets done. So next, with the bigger kerrison, you can perform a faster flavectomy, and I like to think that it's actually safer too because it reduces the number of punches or the bites that you have to do, and you can perform a nice flavectomy done like this. So now moving on to the procedure, here are the things that I consider when I'm approaching or targeting for the index level for ULBD. As you know, the endoscopic surgery is quite physically tolling for the surgeons. So I like to be as ergonomic as possible by working more straight down and lowering the bed as much as I can so that it takes the shoulder and as much as I can also the elbow out of the equation so that my hands are fairly low on the table. Next is the drill starting position. So according to AO principle, the ideal position to start drilling is on the caudal edge of that lamina. For example, if you're doing L4-5 decompression, the bottom of L4 is where you want to start drilling. And this is going back to that feed rate, right? So if you grab the drill and feed it against the bottom of the lamina aggressively, that's how you do an efficient laminotomy. Next is the shortest distance from the skin. So in case like here on a smaller patient, the pivot point where the skin is, you can easily steer the scopes around. And as you know, with ULBD, you have to cover a large surface area from pedicle to cranial to caudal, and also from ipsilateral pedicle to contralateral pedicle to cover that ground. Whereas in larger patients, or take a transforaminal approach as an example, this puts the pivot point close to the proximal end of the scope. So it makes the steering around the surface, around your target, fairly challenging. So that's another thing that I consider when I'm docking the cannula, that shorten the distance as much as possible. So once I'm docked, this is somewhere I like to dock, not exactly parallel to the disc space or where it is, not like a tubular approach, but I want to end up in the caudal aspect of L4 so that, again, I can start drilling there aggressively. Here's the AP X-ray. Once I'm docked, you can see the interlaminar window outlined in red, the bottom of L4, and medial to the medial pedicular line. Once you insert the scope, you will be dealing with a lot of fatty tissues and muscle fibers. I used to remove all this, but now instead I try to sweep away as much as possible and try to find a drop-off of that L4 or the caudal edge of that L4. And once I find that edge, I start drilling right away. One thing I realize is that as you make the laminotomy or the crater or the cavity that the drilling creates, that puts the scope underneath all the muscle fibers, so you really don't have to move all that muscle fibers. And that way, you can be less invasive too. If you use the high-speed drill system like myself, you will be dealing with or contend through this bone dust, and we call this the snow globe effect. If you wait until this clears and then stop and go, this slows down this part of the surgery quite a lot. So I think the anatomy of how you drill and starting position and which area is safe and which area is dangerous is, I think, key to doing this step efficiently. So on your far left, this is the MRI of a patient with severe L4-5 stenosis. And the right three images are a little bit gantry, a little bit off of the paracentral area where I start drilling. So you can see that the flavum is outlined in yellow, kind of paracentrally, and then I outlined the CT on top of that. You can see that as by landing on the bottom of L4, and now that I'm protected by ligament and flavum below, I can aggressively steer that drill against the bottom of L4 cranially. And as I'm steered the drill cranially, I know that I'm protected as long as I don't plunge deep, right? So I move the drill side to side, again, going back to the feed rate, and that green bubble is where it's very safe to drill, and I drill through that bone dust, even though I really can't see. If you think about how we perform the endoscopic spine surgeries, we have three sensory modalities. First, visualization. Second, the tactile feedback. And third, the sound of the drill chatter. So when you're drilling, the visual cue is gone away, but I still have the tactile feedback. As long as I'm on the bone and hear that chatter, I am safe. And these red circles are the danger zones. For example, and you have to drill this area in order to release the ligament and flavum's attachment so that you can do a complete flavectomy. But the area that is especially dangerous, I think, is the cranial end of that L5. Because that area is purely a cortical bone, if you're not careful, you can completely plunge and get a durotomy. This is the workflow in coronal consideration. Again, going back to starting drilling on the caudal aspect of L4, you first want to find a midline that will orient you where you are while drilling, and also you want to perform a complete flavectomy cranially, and then moving on to the caudal level or the cranial aspect of L5 to release the ligament and flavum, and then you go to the contralateral side. And this kind of U-shaped cut on top and J-shaped cut on the bottom is something that Dr. Chapman described in Efficient Laminectomy in his Seattle Science video. This is the workflow in axial consideration. So you first want to do the lateral recess drilling, followed by spinal laminar junction drilling, so that this creates a space for you to lean the scope towards you and go contralaterally and do an over-the-top decompression. And once I'm done drilling, this is what I want to see, and this is what it looks like. You can see on the left, the cranial attachment of the flavum is detached, and on caudally, the cranial attachment of the flavum on L5 has been released as well, and this is the midline right here. And then you have to decide what are you going to do with the lateral limits, and depending on which level you are, depending on how the ligament and flavum looks in each patient, your strategy can become different. For example, in this patient, the flavum ends abruptly in the medial facet. In this case, you can release this with the drill and save time instead of using the kerrison. And this type of anatomy tends to occur in upper lumbar spine, whereas in lower lumbar spine, the flavum wraps around the facet joint and go into the foramen. So frequently, because we're doing L4-5 decompression, my preferred method is to use a large kerrison, but instead of biting or punching the flavum, I simply grab and shear along the fibers of the flavum from the cranial to caudal and caudal to cranial so that I can perform the flavectomy. By saving the numbers of punch, you reduce the risk of duotomy, and you can do a more efficient flavectomy. So I oftentimes just kind of measure how much I have to get out when I'm doing decompression. It's usually between 15 to 20 millimeters on each side. And what's nice about the drill bit that I use is 5 millimeters. So I use that as kind of a fiducial to measure from midline to lateral, and I can and you can see that so that I know that I've done an adequate flavectomy and decompression. When doing multi-levels, I use the same principles and techniques, but I did wanted to point out a few things. That laminas gets very narrower going from L4 to L1. So if you have a starting position here in lower lumbar spine and keep walking up, that puts you in quite lateral to that, close to the pars in the lamina if you don't make this conscious effort to stay close to the midline here. So the reason I want to point it out is because if you're that close to the pars, that's where this dorsal division of dorsospinal artery, or we call pars artery, are, right? So once you hit that, and if you get an arterial bleeder in endoscopic surgery, you know that it can be quite difficult to control that bleeding. Another aspect to doing multi-level surgery is that as you walk up the spine, the laminas get taller and taller, and they become more vertically oriented. What that means is that what my approach has become is that for lower lumbar spine, I tend to use one incision to do L4, 5, and 5-1 for sure, but as I come up to the upper lumbar spine, I make a separate incision because I know I have to cover more ground. Here's an example of a 64-year-old with multi-level stenosis. I use a jumping technique to duck over the fascia again to perform the decompressions. So here's an example of a patient who underwent L3-4 decompression. As you can see with the uniportal technique, you can achieve adequate decompression, but also note that this was done from the left side. You really don't appreciate much of the iatrogenic muscle atrophy here at all. So I really don't consider these procedures to be destabilizing at all. So any patient with prior hardwares or even a severe spondylosis or scoliosis, as long as they have leg pain, this is my approach to go to instead of extending the fusion. So in conclusion, we discussed the strategies to increase your efficiency with the tools, ideal approach for ULBD, laminotomy steps, flavectomy, and multi-level considerations. I'd like to invite everyone here to Spine Summit. Dr. Hofstetter and I are planning an exciting endoscopic session in conjunction with Comey Society. And sincere thanks from Tampa. Thank you very much.
Patrick, loved your talk. Two quick questions I have for you. You know, when you do the approach, it looks like your x-rays, you go straight, you just do an end plate view these days. Do you tilt again, or do you just?
No, I realized that, so if you tilt the C-arm to get the end plate, the inner laminar window over the disc space works very well for discectomy at 5-1. But as I go up the lumbar spine, the distance becomes so great because now you're working diagonally towards that interlaminar space against the disc. So on AP, when I target, there tend to be somewhat end plate view, but also at the same time on lateral view, I want to make sure that the distance from the skin to the bottom of the lamina is also somewhat not too long. I want it to be ergonomic. Distance is short, and also I want to have that drill starting position on the caudal end of that cranial lamina. I think about these three things so that I can do an efficient bony drilling and do a decompression.
And the upper lumbar spine, it doesn't work
Yeah.
as well. So that's a really good point.
Yeah.
Can I ask a question?
Oh, yeah. Yes.
So, how long does it take you to do this compared to let's say, an open procedure?
Yeah, of course. So I'll be honest. When I started this, I think it took more than an hour, maybe an hour and a half. But now, I did 3 of these on Thursday, and they all took less than 45 minutes.
Really?
But I still think that I can do a quicker decompression with tubes. But with these, I really don't have to think about duotomy or CSF.
Seriously, from skin incision until you pull the scope out, 45 minutes.
Well,
is less than an hour.
Yeah, absolutely. This can be done. This can absolutely be done. And there are many YouTube videos. The thing is, we talk about the speed of surgery a lot in uniportal endoscopy, but nobody talks about speed of tubular surgery, right? And I've seen a great tubular surgeons that do 18, 20-minute decompressions. I've also seen other tubular surgeons do an hour and a half decompressions. So I don't know why it's so much. I know that uniportal techniques can be technically more complex, but I do think that it's a worthwhile endeavor, in my opinion, because patients recover quicker.
Over 2 hours to do this.
What's that?
I hear people that are taking over 2 hours.
Well, so that's why, let me go back to my beginning slides here. It used to be that way, and I agree. This was not a very easy procedure, but our scopes has gotten better than ever. And 5 to 6 millimeter burrs. Like I said, in open surgery, we use 3 millimeter drill bits, and we use 4 millimeter Kerrisons. But with tools, by idealizing, having an ideal tools, you can make these procedures that much quicker. And some procedures are tough, right? And I actually had a very difficult case. With the patient with the morbid obesity, patient with prior surgery, overgrown facets, that case took me an hour and a half. I'm not going to say that every case is going to take about 40 minutes.
Sure.
Absolutely not. Laminotomy is not a laminotomy, but as long as they're healthy, reasonable, straightforward pathology, even with the synovial cyst, I do think that everybody can aim for performing this procedure less than an hour.
Excellent. Thank you for advancing this technology.
Yeah, of course. Thank you for the question.
Great talk, Patrick.
Yeah.
My only, I actually have a few questions. Is bleeding? I'm a novice endoscopist, but when you're in bleeding, I can't get it to stop. You're just sitting there. I feel like that's the biggest. When you're in a tube, you generally get it to stop pretty quickly.
I think.
I mean so that's one question.
So I think it depends on approach and what you're doing for that too. If you're hit an arterial bleeder, that's going to take up your time significantly. So if you're doing a transforaminal case and if you're having an issue with bleeding, likely it's an arterial bleeder that follows the exiting route. If you're doing an interlaminar case like a decompression, it tends to be the bleeders, as long as you stay away from the pars, the bleeders tends to come from the bones. So the prevention is key. So all my patients, they get TXAs before and after. My team, and that literature comes from orthopedics, and all my day before my endoscopic cases, my nurses, have these bags. And they heat up the irrigation in the blanket warmers, and that literature comes from ENT for epistaxis. The warm water activates the enzymes, right? Blood pressure systolic around 100, and that comes from sports medicine literature to decrease the bleeders. So it's all about prevention. And when I localize with the spinal needle, I also put in the local with epi in it, and also epi in the bag, right? So all this combined, plus knowing the anatomy, where to avoid arterial bleeders, and if it's a bony bleeders, I tend to move quick. Again, going back to drilling and make the laminotomy bigger so that the irrigation will wash away. So a drop of blood may turn the whole screen red, whereas if you have a bigger crater in the bone, it kind of washes out quicker. So at the end, I use the Surgiflow or Flow Seal to get the bony hemostasis.
Okay.
And the blood pressure is huge, especially with the venous bleeding. There's a huge difference between systolic being around 100 to 130. There's a huge difference. So at the end, after I do a decompression, I also do a gram of TXA again.
All right. Oh, great. Thanks, Patrick. We're interested to see how you do it in the cadaver lab too. So I think our next speaker is